live now? Okay, terrific. Good. I will call the meeting to order. It's great to see everybody. I actually hope that our next meeting in the fall will be in person. That would be really nice. But I think this has worked out pretty well, so it's great. As usual, we will begin with the minutes. I know they were sent out in advance. Does anybody have a motion? You can just raise your hand to approve the minutes. Thank you, Laura. Second, thank you, Meredith. Would anybody like to comment or add or delete anything in the minutes? Hearing none, I would like to have approval of the minutes.
I believe for these online meetings where we do roll calls.
You're right, I forgot.
And I apologize, did we provision Faye with a list of names? If not, I can, I guess you can see them on the screen perhaps.
That's one of the best things about Zoom. I can see.
It truly is.
Okay, I will go in order of how I'm watching you, although some of them are off. Okay, so I'm going to start with Cassandra.
Yes.
Thank you. Lauren, you're going to have to unmute.
Yes.
Laura.
Yes.
Niels.
Yes.
Meredith.
Yes.
Eric.
Yes.
Did I miss anybody? No, Colleen, you were standing in, right?
Yes.
And Rob.
And Rob.
Yeah.
Sorry, Rob.
Yes.
And Rob. You were the first person I started talking to. I apologize. Okay, you've all said yes. Thank you. The minutes are so approved. And now I can turn it over for a report from Ray on where we are with the Apcd.
Thank you so much, Vice Chair Donahue. Members of the Oversight Council, welcome. It's nice to have you here virtually. And as Faye said, looking forward to having at least an option for physical presence at our September meeting. So we're working on the details and we'll communicate with people by email before that meeting. But hopefully we'll be having an in-person component that would be great to see many of you there. All right, do we want to switch to the slides, Alex? There we go. Okay, next slide, please. We've approved the minutes and next slide, please. Are we doing the public, and forgive me for,
No, it's fine. I had, in my head had APCD, but do the executive director's report first. It's
exactly. And Emma, are we going to do the publications before I do the budget? Forgive me for, I don't have my printout of the slides right in front of me.
Whatever
I thought I was doing the budget
like
first. Pardon me?
Whatever order you would like to go in.
Sure. Why don't I'll give a quick budget update, then I'll hand it off to you for publications, and then we'll go into the material, the TF materials for the reports that we're going to give today. So, okay. So first to the budget. Want to let the Oversight Council know that Chia's budget is in the process. You know, the legislature is still working on the fiscal 22 budget happily, and there are some outside sections in play that do affect Chia, so we're following it very closely. Chia's appropriation, which we then assess on payers, providers, and ambulatory surgical centers. That number is 28.9 million, and that has remained steady through the House and Senate. And so we don't expect that to change in conference. So from a budget perspective, we feel like we know what our fiscal 22 number is and we'll be in good shape. Fiscal 21, we're still, the year isn't quite over, but you know, we're closing this year out as we have the prior years, working with A&F on capital funding as part of our solution for funding Chia's core operations and making the CHRTF payment. I believe it'll probably not be till shortly after the actual end of the fiscal year. It'll be in the accounts payable period, but very soon, within a week or two, Chia will be making the fifth and final payment to the Community Hospital Reinvestment Trust Fund. We will have paid $45 million into the fund over 5 years. And it's been an effort, but we've worked very closely with the OHHS and A&F and the Ways and Means Committees, and she has worked very hard to be prudent with its resources, and that saga is coming to an end. So the way the state budgeting cycles work, Chia doesn't drive really anything. We work with all the entities that I just mentioned at the appropriate times of the year to sort of carry our case to them. So it doesn't really lend itself to the quarterly cadence of Oversight Council meetings. What I will do in September, now that the 5 years of the Community Hospital Reinvestment Trust Fund payments will have concluded, is to give a full description of kind of that 5-year arc. it was kind of hard to do during the ARC because each year was, kind of its own act of creation. And, while you're in the game, you don't really want to do the kind of the summary of the game. But now that we're coming to an end of the 5-year period, I think it's reasonable that I should sort of sketch for the Oversight Council kind of the full 5 years and what Chia did over that time to comply with the requirements of Chapter 115. So that's Chia's budget status. We're working to close out fiscal 21. We will again balance our budget and make the CHRTF payment. And for fiscal 22, we're waiting for the final disposition on the state budget. We believe we know our number, but we're looking at some of the outside sections. So that's the budget update.
I was gonna say, did anybody submit any written testimony on the budget?
At the budget hearing, thank you very much for raising that. We had our statutorily required budget hearing in the spring, but there were no one appeared. There were no questions and no testimony. So it was, the formality of holding the meeting and offering that opportunity, but there wasn't any. There were no testimony.
And nobody submitted any written testimony later?
No, and no written testimony later.
Terrific, thank you.
You're welcome. So are there any other questions about Chia's budget or finances? That's kind of the end of my update on that. All right, hearing none. But as I said, in September, finally, we'll have actually a longer and more detailed, certainly more detailed presentation with numbers and charts and going over the full history of the 5 years from the passage of Chapter 115. Okay, let me turn it over to Emma for the publications update.
Thank you, Ray. So as we've done in previous meetings, I'm just going to quickly walk us through the publications that have been released since our last meeting and then looking ahead to what's next. So since March, we have released a quarterly update on the hospital inpatient discharge data that had data through the end of 2020. We've also published 2 hospital financial performance reports. The first one was a preliminary FY20 report, and we also published a quarterly report with data through December 31st, 2020. Additionally, we've continued to publish our monthly enrollment monitoring reports. The most recent one had data through March 2021, which we were really excited about because it marked 1 year of enrollment data since the outbreak of COVID-19 in Massachusetts. And then continuing on, we released the last 2 briefs of our series, An Inside Look, Affordability Findings from the MHIS. And then last month, did an update on the National Healthcare Data Statistics and released the 2nd edition of our newsletter, Data Matters. And then regarding data assets, we released case mix hospital inpatient discharge data. And it's not on the slide, but one thing I do want to note, it's not our typical publication, but we did deliver 3 mandated benefit reviews to the legislature since March as well.
What were they on?
So one was on, you're going to test me, one was on genetic craniofacial conditions. Another one was on pregnancy related services. And then one was about fertility preservation. And they're all available on our website. I'm happy to send those links out after the meeting if you're interested.
But it's a good reminder for all of us, we can check the website. Stuff gets on it all the time. Thank you.
Of course. So looking ahead to what's coming up next, we will have a few more reports on hospital financial performance. The first one will be a quarterly report with data through the end of this March, as well as our annual report with FY20 data. We will also be releasing our annual relative price and provider price variation report. And then in terms of our new reports, we have one coming up on emergency department discharge data and a new research brief on unmet social needs. And then lastly, we will be releasing the next edition of Data Matters in July. So that'll be meeting the 2-month cadence that we're looking for the newsletter. And then we will also be releasing case mix emergency department discharge data. Are there any questions?
That quick run through in some ways gives you a sense of it, but it doesn't do justice to just the enormity of the work that goes into creating that many artifacts, just the data intake, the quality assurance, the data normalization, the analytics, the preparation of the publications, and a lot of these publications, and you saw some of them designated as new. A lot of these were things that we used to do on an annual basis that we're now doing quarterly, in some cases monthly. there's just a lot of work that's been going on. And yeah, I wish my job only entailed reading Chia's publications. I'd be a lot smarter, and it would be, I mean, there's just a huge volume of really interesting stuff coming out. So thank you, Emma, for that summary, and definitely encourage the Oversight Council members to either, kind of scan the website yourself, or if there are topic areas you want us to maybe guide you, we'd be happy to do that. We frequently get outreach from, different public sector entities, the legislature or state agencies wanting us to help them dive deeper on stuff, and we're happy to do that really with anyone. So anyway, thank you, Em. Very good report.
Yeah, thank you, Em, and thank you everybody for all the work that goes into it. Do you have any sense, Ray, on which are the ones that people are reading the most, based on just not specific data, but just your gut? Which are the ones that people are really finding useful?
That's a great question. I think it's different populations key in on different publications, and so we've heard, for instance, relative price was one of the publications you've heard mentioned. We've heard that that's often referenced by the payers and providers in their contract negotiations. So I think it depends on the publication, but it's also true. Today we're going to talk about Chia's sort of a survey of all of our analytic areas. At the next meeting, we're going to talk about some of our priorities. So as opposed to describing the current state, we're going to talk about priorities. One of our priorities is to come up with some better communications to improve the way we communicate, because there's such a large volume of information going out. We think we should do a better job of channeling it at different populations. And then to your point, being able to track some metrics. So I don't know if Andrew or Emma, if you've got anything you can share on this call. If not, we can report back at the next meeting. But the truth is, that's something I think we should do a better job of as we get better at sort of dissemination, also be tracking how many users and, if possible, sort of where they're coming from. Because I do think there's our different issue areas attract different interest groups.
Yeah, I think there's so much that one could do, and there are so many things you're already doing. And as we talk about the analytic agenda later, we might end up adding more to the plate. The question always is there anything you can take off it?
Exactly. Okay, great. Well, thank you so much for that update, Emma. So let's turn now to the first presentation. So we're going to, let me just tee this up briefly and then turn it over to Ashley Storms, who will do the actual presentation. For the last year, our meetings have been very focused on kind of the here and now. We've talked a lot about Chia's transition to remote work. We've talked a lot about Chia's work for the command center, about our increased cadence of data collection and data publication. But today we're going to look at two things that have a distinctly longer arc, and I think that's important. The first is the Apcd Enhancement project. The second is our analytic agenda, starting with an analytic framework. The Apcd Enhancement effort is the largest project I believe that Chia has ever undertaken. We've been working on the Apcd for more than a decade, probably close to 15 years. It has continued to evolve, but I think we are now right at the finish line of building what it was that we had set out to build 4 years ago. There's still a few more things to be done. Ashley's going to walk you through all the details, but I hope you'll be impressed by how far this has come. Claims data is really very little more than just raw EDI codes, and to actually turn it into something that is analytically useful to healthcare analysts is actually a pretty heavy lift. And so Ashley's going to describe what's been done and where we're at, but I'm very pleased, even though it's been a heavier lift than we ever expected. We are at a point where we're very close to a successful completion of the project. I do want to particularly thank Deb Scheel for her efforts in getting us to this point. She has done incredible work over the last 4 years, guiding our Apcd implementation effort and leading our health informatics and reporting department within Chia. So she has really done an extraordinary effort to get us to this point. Ashley's going to be doing the actual presentation, so I'm going to turn it over to her. So Ashley, take it away.
Thanks, Ray. So we can go to the next slide. And before we start, jumping into the project update, I wanted to step back for a minute and give some context of where we started. Speaking specifically from my experience as an internal user of the Apcd. And I believe for the most part, what I'm going to share on this slide will also ring true for our external users because it's similar to the level of access that they currently have. So prior to this engagement with IBM, there were a relatively small number of users at Chia who had both the technical and the subject matter expertise to dive directly into the database and analyze the data. So our analytic teams relied on these experts to transform and summarize the data into smaller, less complex data sets that we could then read into Excel or Tableau to do the bulk of our analytics. And as an example of the challenges that a user would face, the member eligibility file that payers submit includes records that represent variable enrollment periods. One record could represent a single day of eligibility, or it could represent 24 months or anywhere in between. And we could potentially have more than one record per member on a given date. And so, a user really had to know a lot and be very skilled in order to transform and deduplicate these records in order to avoid double counting. The claims data is more straightforward because claims are standardized. But we were getting payer submitted values from national code sets like revenue codes, procedure codes, and sometimes, bad codes would slip in or non-standard data, and a user would have to deal with that on their own and figure out which codes maybe wouldn't be useful for analysis. But we didn't have, descriptions attached to them or analytically useful groupings. So those are certainly not insurmountable problems, but they were an extra step that had to be taken for analysis. And so you can imagine an analyst going into the data and they're seeing a group of claims with an ICD-10 diagnosis code, and it's something like W61.43. And they would have to, look that up, go to some external reference source to know that those were patients who were attacked by turkeys. And if you live in Brookline, maybe you've seen that happen. And then of course, those are just relatively simple analyses, but more complex encounters like hospital admissions or certain outpatient procedures that can span multiple claims would need that logic to be developed from scratch. So where are we now, you might ask? So what we have right now are analytically ready data marts, by which I mean that they have solved for those constraints from the previous slide. And most Chia users will be able to access them through Tableau, R, or a SQL client, depending on their skills and project needs. In fact, many Chia users are accessing them today if they're part of the testing piece of the solution. Our eligibility files, including the MassHealth Enhanced eligibility file, have been transformed into member month tables, which means that an analyst can now more easily select one record per member per month for their enrollment reporting. Our claims data sources integrate reference data from national standard code sets, but also pharmacy therapeutic classes from Redbook. NPIs have been linked to the NPES National Provider Registry, as well as to the HPC's hospital crosswalk. So in many cases, we can roll up data to hospital level when we have those NPIs that match. We also have included Chia custom analytic groupings and measures. And examples of some of these custom measures that we've created include financial measures that account for differences between how capitated and non-capitated claims are submitted to the database. We have telehealth indicators. We have market sector and product type groupings that match what we currently report. And we've included MassHealth specific eligibility classifications to help people kick off their analysis. We've also been working really, really hard in partnership with IBM to build Tableau data sources that have drag and drop reporting capabilities for per member per month financial amounts, so that a user can pull in key eligibility or claims attributes and have those PMPM measures recalculate, which is, if you've ever tried to set up PMPM reporting, this is something that can be very challenging for a user to set up in a way that's flexible and allows you to redo the results whenever you pull in new information. So we're really proud of that. And this week, we're also getting access to the first 3 modules from IBM's Flexible Analytics package. And so that includes the inpatient admissions grouper, service categories, which will allow us to roll up claims to meaningful categories like facility inpatient, or going down a level, facility inpatient maternity services, as well as disease staging, which classifies clinical conditions and their severity according to the claims data. And I want to pause here and just acknowledge that there are a lot of really talented people working behind the scenes, and they've been working, tirelessly to design and restructure and configure this data. And we're so proud of what they've accomplished and where we're going next with this solution. Next slide. So as the development phase of the project winds down, we're going to be receiving the following enhancements. Member PCP relationships, which were previously nested in the member eligibility data in a way that made them challenging to analyze, will be tracked in their own dimension for improved reporting. Claims submitted by the managed care plans like MCOs or SCOs, as well as dental claims, will be integrated into the MassHealth specific Tableau data sources. We're getting a new interactive report called Member 360, which reports member level spending and clinical conditions. And this was designed in partnership with the HPC to meet a specific analytic need that they have. We're also getting a host of additional flexible analytics modules, including additional groupers, risk scores, and HEDIS-like quality measures. We'll be continuing to work on refining the data marts and Tableau data sources, and we'll be moving to a quarterly refresh schedule within this IBM solution, which is going to allow us to have more timely analysis, moving from that annual release process that we had in the past.
Just to jump in there for 1 second, Ashley. So imagine it used to be that extremely difficult to access asset that was produced once a year. We will now have this greatly enriched and much easier to access data asset, and it's going to be an online, you'll access it through a portal, and the data will be refreshed on a quarterly basis. So it's just a dramatic improvement in the power and usability of the Apcd.
Certainly. And there's a lot this platform can do, and the greatest amount of flexibility is still going to come from a tool like SQL or R. So rest assured that option remains available, and many users will continue to access the data in that way. But today I'm going to focus more on Tableau because it's both a new entry point to the data and because we believe it's going to open up the Apcd to users without a strong coding background. And as you can see from this table, there are quite a few Tableau data sources to choose from, and they're focused on specific topic areas. And they have with built-in links to other Apcd file types and reference dimensions. This means that a user reporting on medical and pharmacy claims will also have access to fields from the eligibility, product, and provider files, as well as relevant reference data. And they won't have to know what keys to join on or how to make those tables work together. It will all be already built into the Tableau solution. And so at this point, I'm going to share my screen and then give you a brief introduction to our Tableau server interface. So please be patient. Okay. So our business intelligence tool for this engagement is Tableau, which I just mentioned. And all of this runs through the web browser, which is this Tableau server interface that you're seeing right here. Now, users that have appropriate credentials will be able to download workbooks and open them in Tableau desktop. All the data will remain stored in the database securely with security precautions. This page right here is where the user will go to create a new report. And the folders that are linked include data sources and also blank starter templates for creating their reports. So going down the list, we have data quality reports that are speaking more to the mechanics of the data and will help us communicate back to our data submitters where the quality might be lacking. There are linked marts that include linked claims and eligibility data sources, including our admissions data source. There are data sources that are specific to the MassHealth enhanced eligibility file, the member eligibility file, and those per member per month financial reports that I mentioned earlier. The system also has an area for users to save their own reports so that they can come back to them in the future or allow other users within Chia to view them, assuming they have the same security permissions. So I'm going to open up a report that I've previously saved. And I'm going to start here. So before I start explaining what you're seeing, hopefully it's not too small on your screens. I'm on a fairly large monitor. I'll say all this data is running in our test server, which is a 700,000 member sample with 15 months of claims history. We do have a full 5 years of data in the production server at this moment, but as a software development best practice, we've been conducting our testing in the test environment so that we can iterate more quickly. So that's why what you're going to be seeing today is focusing on calendar year 2015.
Yeah, sorry, actually, I think I know the answer to this, but is this a on-premise or cloud, your servers?
I believe it's not on our premises, it's on IBM's data center with a VPN tunnel connection.
Got
Right,
it.
I think it's
Thank you.
technically not the cloud. I think it's an IBM.
Not the
data
cloud,
center.
yes, it's a physical
But yeah, it's not
database.
at 501 Boylston. It's not
Okay.
on state infrastructure.
Right. So you guys don't have to like do like pay as you go or anything like that for your queries or any of those type of
No,
pricing models?
no,
Okay.
no,
All right.
it's paid, yeah.
Fantastic. Cool. Thanks, guys. Sorry.
Man, if it was pay as you go, I'd hesitate to see the bill that I racked up already.
Absolutely.
So when a user opens one of these template workbooks, let me just get a pointer up here. What they're going to see at the beginning is an area where they can select their incurred date range. I've gone ahead and put in calendar year 2015. And other than that, they're going to have a blank canvas to report whatever they're interested in. On the left-hand side, we have a list of folders that include fields organized by file type and subject area. So there are a variety of attributes in here from IBM's proprietary flexible analytics model, as well as fields from the medical and pharmacy claims files, member eligibility, and links to our provider reference data. And just to give you an idea, I can click into one of these folders. This is the medical claims HCPCS CPT procedure codes folder. And what we have here are a variety of higher level groupings, these procedure category level 1 and level 2 codes with descriptions. So that's going to group our procedure codes for reporting. We also have the original procedure codes and descriptions to accompany them. So if you do need to do more granular reporting, those codes are all here and they're accessible. So I'm going to go through the basics of setting up a report. And the concept that I want to share with you today is just reporting medical and pharmacy claims spending over time. So I'm pretty familiar with this data source. I'm going to just use the search bar to more quickly find the fields I'm looking for. I'm going to pull in this one called claim category code, which is going to stratify our results into medical claims and pharmacy claims. And I'm also going to pull in the incurred date. Now, right away, what you'll see here is that Tableau has recognized this as a date, and they've currently aggregated it to the year level. I'm going to click the plus sign and drill it down to a quarter, because I don't think aggregating by year is going to be very helpful when I've already set our date range to calendar year 2015. Now for our spending measure, I'm going to go to the measures folder. And in here, you'll see it's a very long list. It's all of the measures from our claims files, many of them financial amounts. So we've got the allowed amount, the charge amount, postage, co-insurance amounts. The field that I'm going to select for this demonstration is the total paid amount field. And that's a Chia custom field that we've derived that is going to add up the smaller fields that represent what the payer pays and what the member pays. So that's our total paid amount field. So I have my report set up. I'm going to click run. And when I click that play button, what's happening is that Tableau is writing a SQL query according to the specifications that we've set, and it's sending it off to Oracle, to the data center, and then bringing those results back. So here we have our results for medical claims under MC and pharmacy claims under PC. We have spending by quarter. And if I say, okay, I did that so I could see that I had what I was looking for. I really want to see this by month. I can go back up to the plus sign. I can click that in Tableau. We'll rerun that query at the month level. And if I wanted, I could even go down to days. Okay, so now we have total paid amount by month for calendar year 2015 by medical and pharmacy claims. And I might just pause there and see if there are questions.
I'm loving it. I don't have any questions, but it looks great.
Thanks, Ray. So I have another report that I've pre-built that I wanted to share with the group. It probably would take me 10 to 15 minutes to set this up just to get it exactly the way I want it. So I went ahead and did this ahead of time. But the use case here is an analyst who is looking into spending on respiratory diseases. It seemed like a salient report for the current state of the world that we're in. So there's a lot going on in the filter shelf. And let me again spotlight that for you. So this area right here of Tableau is where a user puts their filters. And this is really representative of the level of subsetting that a Chia analyst would typically do at the beginning of an analysis. And you don't need to understand what all these filters are. I can summarize it for you. So what I've done here is I've drilled down to medical claims for Massachusetts residents with primary medical coverage. And I've focused even further on fully insured commercial products and those claims that have a primary diagnosis of some kind of respiratory disease. So turning our attention to the visualization in the middle of the screen, what we're seeing is total spending in 2015 for each individual diagnosis code that's within that respiratory diseases group. So before this solution, what we had was just these numeric codes. Now it's very easy for a user to grab the description, to grab the higher level groupings like those respiratory diseases. That's how I subset this. And it's all at your fingertips. Now on the bars, I've broken this down into a payer paid component in blue and a member cost sharing component in orange. I think that's a good first step for this analysis. And what I can see here is that overall in this population in this year, the highest spending was on acute pharyngitis, which is a sore throat, relatively common condition. And in the tooltips here, I was able to create a calculation to see the percentage that cost sharing represented of the total spend. And so I can see that for this condition, for this diagnosis, members covered about 28% of the total cost. And that was relatively quick once I knew Tableau syntax to create that calculated field on my own without going to somebody who could code it into SQL for me and add it to my visualization. Now, obviously, this is a pretty simple report. It would be a starting point because if I look down this list, I'm seeing, seems like there's a big jump from sore throat to acute respiratory failure. It looks like there's a wide range of differences across these diagnoses in terms of the acuity, probably the average cost per patient, the number of services received, the setting of care. And so that's definitely something that an analyst would want to drill down in. This would be a starting point, not the end of their work. But the information that they would need to do to undertake that analysis is going to be found right here in the fields list. At the very least, to explore their data to the point that they have a very specific research question. And if they needed to at that point, they could still target a more complex SQL analysis. But at the very least, what they have right here is a really powerful tool for exploring the data and doing some initial reporting. So hopefully that gives you an idea of the current capabilities and how a user would interact with the system.
Yeah, that's really impressive. Just a quick question. I was wondering, have you guys done any like stress testing? Because I mean, the performance looks great with actually with you driving. I was wondering if you bump this up to like 40 users, 50 users, 100 users, like the things start to grind out, or?
Well, Ashley, I don't know if you want, I mean, I can take that and then you can maybe correct me if I say anything that
Sure.
not to be true. So it turns, I mean, performance is something we've been very attuned to, kind of from the beginning. Something I know that Deb has talked about from the beginning, Mike Kochi, our CIO. In December, as we were starting to get some of the production environment stuff, we were not happy with what we were seeing from the performance. And so we had a lot of meetings with IBM. They have been a great partner. And I've said this before, that this project has just been consistently difficult, but they keep stepping up and we keep stepping up and we keep, getting things done. So we've been actually very focused on performance for about 6 months. They've done some significant reworking of the whole data model to enhance performance. They've, I believe, also done, hardware and software enhancements. Some of the performance issues related to issues with Tableau that were just in Tableau. And because IBM is a large enough customer, they've been working with Tableau on improvements literally in the Tableau foundation. And so they've rolled out code to us. We're in the process of doing that. That will also eventually make its way into the core product. So performance is something we've been very focused on. We're not yet running, 40 or 50 or 60 users, but that's the type of thing that we want. And so I'm confident that we're going to get there. But it has been, as with everything, it feels like we achieve success, but after great effort.
No, thanks, Ray. And then this is a little bit of like a weedsy IT question, so I apologize. But and then I know Ashley, you were saying that like people can write their own custom like R SQL queries. I was just wondering if like any thought to like controls or monitoring of that type of stuff, like so nobody's running like a 200 billion Cartesian like in your servers, like crashing everything.
I do know that IBM is implementing database monitoring for us, and we're actually working with them to get more insight into that, to see if there's a way that we can give even users a look at what queries they might be running behind the scenes that might be slowing things down, or give us more information on server traffic on a given day. So that's something that we're talking about.
Fantastic, thank you.
And I should also be clear, our intention is this tool will be available for native use by any of the state, the core state agencies. So that's folks at the auditor's office, the attorney general's office, EOHHS, HPC. Certainly, they're sort of our kind of our primary. We're sort of, when we think of external users, they're kind of our first power user use case. DPH, the GIC, the connector authority. We see a lot of folks eventually being natively on the system. So we're leading the way, but we want this eventually to be a resource for any agency that needs it. And so that does suggest we need to be able to support a lot of users.
Ashley, great presentation and great tool. This is a huge advance. And as you were going through some of the complexities, I had a bit of an inkling from having served on the council for quite a while, but it was really good to get that recap of really how hard it was to try to piece something together. Question that I have around, would something like a national patient identifier, recognizing it's one of the third rails of digital health, but would that have any implications for the ease of pulling things together for Chia?
That's an excellent question. And I just want to clarify, you said a national patient identifier, right?
Correct. Not a provider identifier, which we already have, but a national and I realize it's extraordinarily controversial. MITRE is coming out with a new draft digital health strategy, and they're calling once again, the MITRE Corporation is calling once again for a national patient identifier. And I keep hearing it popping up. So I don't know if it ever has a chance, but would it, in the case of Chia, assist us with organizing things for uses of the data?
So I will probably kick this to Ray. I'll say briefly, I know that would be something we would have to think about very carefully, the implementation of, because we've done a lot of work to de-identify our data to make sure that we're not giving out sensitive health information. And so that would be something we would have to take back to our data stewards, certainly.
Yeah, and if using it sort of pre-presentation, of the data just to organize it, but then blocking or stripping out the identifier as a part of a de-identification process. Ray, does that sound feasible, or does that, for you, is that minimally minimally helpful?
Unmute, Ray.
Thank you. Yes, so certainly, I mean, there are the privacy issues that have been the stumbling block, for progress on this front, but, my own views kind of, well, just looking at the data layer. So sort of clearly, a whole lot of the work that we do is because there are not unambiguous individual identifiers. We don't use social security numbers or have stopped using them because of issues around that. And so a lot of the data layer work that we do is trying to figure out who is who. And so even though we de-identify, a world in which we could have some, certain identifier, which we could then strip out and use surrogate keys, so you can't actually link the people back to that definite identifier, it would no doubt make our lives a lot easier. So there's other considerations, no doubt. I really look forward to seeing that MITRE report, because at a data level, there's a lot of work is just to get around that problem.
Yeah, I received that report from Jay Snitzer at MITRE, and he indicated that it was possible for us at the National Academy of Medicine to share. So if it's useful for this group to see that, it's still a marked draft, but I think it's a pre-pub draft is what we're seeing. I think there are some other aspects of it that people are going to have a bit of concern with the strategy, but there's some really, really good aspects to it. So I'd be happy to share that if it's useful for the group.
Oh, I'd love to see it.
Thank you.
Thank you. Okay, well, so I mean, are there other questions for Ashley before we? This won't be the last. We will continue to provide updates on the Apcd, but we're other than it being a really heavy lift, and I do want to thank the Chia staff. I've talked about what a great job our vendor partners have done, but the amount of work from Chia staff who never signed on to be system builders. And this has gone on for years, when it was really, originally thought it was going to be, a year and a half or something like that. So it's been a very heavy lift, remarkable effort by the Chia team. I do think they know the system forward and backwards. So there are benefits to the amount of work we've done. But Ashley and her colleagues have really done great, great work. So thank you so much, Ashley.
Yeah.
Thank you, Ashley.
Mm-hmm.
All right. Yeah, I just want to emphasize what Ashley did. She said that would have taken her 10 minutes. In the past, we would have needed to kind of create a request for one of our SQL experts to create SQL code that would get QA'd, that would get run against the database. The data would get QA'd. It would get, literally you're talking 2 months can go by as opposed to 10 minutes. And for an external user like the HPC, they would need to have, there's a whole additional steps that they need to do to make the data usable. So we're very excited at the data being this accessible and this enriched and available online for our users. So, okay, if there's no other questions on that, we can switch to the final topic of the day, which is a discussion of Chia's analytic agenda. So this is something that has come up many times. The Oversight Council has expressed an interest in this topic. I apologize really that we haven't had a chance to talk about it more. Part of it is Chia's analytic agenda, I guess on some levels you could say, is set by statute. But that's not entirely true, because we have a certain amount of leeway in terms of how we devote our resources, above and beyond the things that we're required to do, and also just in how we interpret the different tasks the legislature has given us. The truth is, there's been the last 5 years since I arrived, we've either been very busy trying to comply with the requirements of Chapter 115 and sort of doing some significant downsizing. The last few years, we've been rebuilding Chia's analytic capacity. And then, of course, the past 15 months have been dominated by the pandemic. So it's been in some ways difficult for us to just even describe Chia's analytic activities, or at least it's been difficult for me. So the document that I sent out to folks, I think it was 2 weeks ago, is our best effort to date to describe. It's a description. It's not a prioritization. That's kind of our next discussion. But it's a description of Chia and the types of things that we do. And I think it's a useful document. It's still a work in progress. We're going to take the input from the Oversight Council. Chia's senior team is also still working on it. But I think it would be very useful to have a relatively concise description of what Chia does, because we're a somewhat unusual animal. We're not, not a lot of states have an organization like Chia. I think that for new employees, for new members of the Oversight Council, for legislative staff, for members of the press, I can think of a lot of audiences where it will be helpful to describe what Chia does. So anyway, this document that I sent is merely descriptive. In September, I think we want to start talking more about priorities and gaps and things like that. And of course, we can discuss things like that today. But today's discussion, I think, is mostly to let people pressure test or ask questions about the framework that we circulated. I'll quickly run through a few slides that summarizes the document I sent out, but I want to keep it short so that we can devote most of our time to discussion. So Alex, if you could flip to the next slide. I've described Chia before. I often do revert to this, to describing Chia in terms of our data assets and then our analytic activities. So once again, and I won't take a lot of time on this because you folks have heard, I have described our data assets for you before, but it does really start with our data. And I think Ashley's presentation about the Apcd gives you a good sense of the kind of the complexity of the data. Shoot, I should have taken the family phone out of the office. Good, it's stopped after one. So Ashley's presentation, I think, gave you a good sense of just how complex the data is, and also how it's the starting point for our analyses. Really, the questions that you can answer is a function of the type of data that you've got, and so this is where we start. So we have a hospital discharge database, which is patient-level information on every single discharge from every acute and behavioral health or private behavioral health hospital in the state. We have an emergency department database, which is patient-level information on every emergency department visit in the state. There is the all-payer claims database, which you just heard about, which, despite gaps primarily in the area of self-insured claims, is an enormous repository for understanding the delivery of service and payment for those services in our healthcare system. Apcd 9.0, which is the most recent release, and that will include 2020 data, is coming very soon. And so we're excited about that. That will show a lot of information on the pandemic. Payer expenditure reports. This is a very important type of data for Chia, even though it's not nearly as large as the Apcd or the hospital discharge database. Chia has the authority to require health plans to report to us on their spending in Massachusetts. So we require them to tell us about their total spending. We require them to break it down by product type, break it down by the zip code of their members, break it down by the service category, whether it's hospital inpatient, hospital outpatient, drugs, physician services. We've started collecting information on, is it primary care or behavioral health spending? So our ability to get these aggregate reports from health plans is an extremely powerful part of what Chia does to measure the healthcare system. Next slide, please. And these are the last three of Chia's data assets that we're talking about. So provider financial reports. This is, I think, Chia's oldest function, is collecting financial information from hospitals, nursing homes, community health centers, and others. This is an outgrowth of Chia's rate setting function for Mass Health. You need that financial information from the providers in order to set rates. And so Chia collects lots of financial information from providers. We do 2 statewide surveys, which are really interesting and important. And increasingly, we're relying on what are called, now I'm blanking on it, callback surveys, recontact surveys, where when we're surveying, we contact 5,000 households as part of the household survey. That's a lot of people. We always ask if we can recontact people, and generally, if people are willing to do the survey, they're willing to be recontacted. During the course of the survey, we'll ask a question that we want to drill down on more, such as, have you or somebody in your family's been a victim of a serious medical error, or are you having affordability problems? A bunch of different issues that we're interested in exploring this way, use of emergency room services and so on. If they say yes, we circle back and do a recontact survey. And what that allows you to do is identify a large population of people in Massachusetts that have a particular issue. And so the depth of the data that you get from these recontact surveys is really, really good. So anyway, our survey work is interesting and important, and we're doing a lot in that area. Lastly, registered provider organizations. Chia collects data with the HPC on medical groups, on their financial condition, and their clinical and contractual affiliations. Okay, next slide, please. All right. So there's only this slide and the next, and then we're into discussion. So this is an attempt to summarize Chia's core analytic activities. I should say, an initial starting point, and I brought this up in the document, is you have to realize Chia is not the home for all data or all health data in state government. We do have, for instance, Mass Health's claims, But there's a whole lot of information that Mass Health has about their members and their population that we don't have. And similarly, the GIC, we have GIC claims data, but we're not the expert on the GIC's members or their programs and such. Same with the Connector Authority. So we hold data from a lot of different places, but we're not, number one, the only holder, but also the Department of Public Health, for instance, is a significant other player in this space. They focus on clinical, or they are more focused among their many other duties, food safety, you name it, the responsibilities of DPH are vast. But in terms of the health data area, they have clinical registries. So they collect a lot of information on the incidence of different diseases in Massachusetts. They have a lot of lab data. Vital statistics is within DPH. So things that relate more to the health and wellness of the population tends to be at DPH. Chia's focus is more on the healthcare system as opposed to individual patients and their health outcomes. So that's just, I think, a useful way of kind of remembering what Chia does focus on as opposed to some of the other organizations. The HPC, as I mentioned in the document, they're in some ways they're not really a data agency. They sort of use Chia's data and pursue do policy work. But having said that, they have the authority to collect additional data from participants in the system when they're reviewing them, and they certainly exercise that authority. They also get a lot of national data to put Massachusetts data in context. So anyway, the point being, there's a whole bunch of organizations within Massachusetts state government that collect data, health data. Chia's focus is mostly on the entire healthcare system. And these are the 7 categories that we think sort of summarize the various activities we do relatively concisely. And I want to thank Lori Kavanaugh, who has left Chia to pursue other interesting opportunities, but was really helpful in creating this formulation. So anyway, healthcare spending and utilization is probably our most fundamental capability. That's something that we see well in the system, at least, once again, not regarding the outcomes, but regarding the spending and utilization. Provider finances and rate setting, as I mentioned, something we've been measuring for many years. We focus a lot on insurance coverage and healthcare affordability. And as the document made clear, and I'm not going to take the time to go through it now, every one of these topic areas, there's multiple data assets that we're using to measure and report on it. So none of these are really a one-to-one. It's all sort of a many data assets are being used for each of these topic areas. Health equity and social determinants of health, we're doing quite a bit. Behavioral health has been a focus of ours for a number of years because it's so important in terms of the impact it has on people's experience of healthcare and their use of the healthcare system. Provider and payer quality. Chia has, because we don't focus on outcomes and clinical, and we don't have clinical data per se, there's things that we can't do in the quality space, but there are things that we can do. And so there's a fair amount of work and reporting we do there. And then lastly, price transparency. We have a very good view of prices in the system. And so we do a lot of reporting on prices, relative prices and such. Next slide, please. And this is the last one. So in addition to those sort of major topic areas, if you will, we also do mandated benefit reviews for the legislature on kind of any type of benefit that they want to add to fully insured products. We support the HPC with data analyses and referrals. So in addition to sort of analytic activities, just kind of making sure that we're ready to support the HPC and their important workflows and processes to the extent that it's our responsibility to do so. We want to be sure we're teed up and doing that well. We do a lot of interagency data and analytics sharing. So I've listed the agencies before, I won't mention them again, but that's a lot of what we do is trying to support other agencies. Increasingly, we're doing data linking. And we really started with the Chapter 55 opioid study, but since then, it's becoming a real line of business for us, doing a lot of linking both internally, but also for other state agency partners. And then lastly, responding to major healthcare system events like passage of the Affordable Care Act, or the opioid crisis, or the COVID-19 pandemic. We take our data assets and our analytic capabilities, and we try to measure and report on those phenomena. So that's the end of my slides. That was just a quick summary of the document that I'd sent out to you. It's not so much questions as it is discussion. I don't know if there's how the document or this little summary strikes people. Does it seem roughly accurate and comprehensible? Are there things you expected to see that you didn't see, or vice versa? Just wanted to get any thoughts or input from the Oversight Council on that description of Chia's analytic activities.
Laura, you unmuted.
Not to dive in first, but to dive in first, I really enjoyed getting it. Yeah, you're right. Because I've been on a while, I've been through this information before. It's always a helpful update for me to go back and refresh my thinking around this and understanding what it is. And in some cases it does morph. So I've also felt like the way that you aggregated the data assets and then the analytic capabilities and the things that are of import that we produce vis-a-vis the reports. So I found it really useful to be able to go over it again. I read it before the meeting to hear you go back over it. It's complicated. You do a lot of amazing things. And so for me, it was a great refresher to have, and also a good something to keep in my electronic files, so that when I'm thinking about when a report comes out, I can quickly go back and take a look at this and put it in context with the other published things that are published by Chia.
Well, thank you, Laura. That's actually, I hadn't thought of that particular use of sort of using it as a, when you, and I should probably even think of it that way, that when I'm looking at a report, contextualize that report, in the larger picture of the work that we do. So good, well, thank you. Are there things that people expected to see, or other, omissions, or?
Right, I think it might be helpful for some of us to distinguish a little bit between different groups and using the data in different ways. And I'm thinking particularly of Chia and HPC. So if there's a system effect, like a expansion, for example, is that Chia? Is that HPC? When you talk about healthcare affordability, is that the affordability of insurance, or is that the affordability of healthcare? And so just help us a little bit understand where things might fit.
David, frankly, can do a better description, and sort of have somebody else. So I don't want to put you on the spot, David, but just have somebody else talk, and it's actually a more authoritative description. But I mean, yeah. Let me David take your crack at it.
I mean, I think you laid it out really nicely, Ray, and I think part of the distinction between our agencies is we are more focused on answering very specific questions or examining very specific issues and using all of the data assets that Chia collects and collates and optimizes to answer questions in the hopes of informing policymaking. And I think it's actually a really we have over time worked to create a pretty synergistic way of our agencies working together, where there may be times where we'll take the data and do a really deep dive on, say, avoidable emergency department utilization. What are the characteristics of these patients? When are they going? What types of services, et cetera? And kind of do a one-time deep dive on that. And over time, though, Chia and Ray and the team start to build some of those things into their basic, their annual reports or their annual data books. And so it doesn't require kind of a special, look in. And so it kind of creates this kind of virtuous cycle of, looking at the data, answering specific kind of questions, but then over time, Chia then starts to kind of build those into their standard outputs, such that everyone can have access and see how those trends, change over time without us necessarily having to rerun that analysis every single year. And so, things like market changes, things like, some of the, legislative, activities where we're both charged with working together on a study of the COVID-19 impact. It's really around working with Chia to understand what data assets they have, what are the limitations of them, and then enhancements of them. And then our team, works within that to then try to say, okay, what are the questions we're trying to answer? So I do think it's always been, I think the best distinction for how I think of it is Ray and his team, collate all of these incredible ingredients. And then sometimes our job is to say, okay, we're charged with making, a nice little refined dish out of it. How do we pull the right things from all of that, as ordered by either the legislature or the administration or whoever is holding the menu at that particular moment?
I think it comes across as more integrated, at least to me, because it's not as simple as saying Chia holds the data and you answer questions. Because I look at the reports that Chia does, and clearly they're answering questions. So it was, as we think about the discussion on, for example, agenda and prioritization, understanding who does what is actually important. And I like the idea that maybe one of the roles is Chia collects it, it becomes then institutionalized after somebody else has done some of the work. So I'm not saying it's a one time fits all, but for us around here, because the Attorney General uses it, the Division of Insurance uses it, lots of people do.
Yeah, absolutely.
And we've actually did our relative price work as an example of the Attorney General used their superior ability, with subpoena power and other things to look deeply into the question of relative prices, figured out a methodology that respected the privacy of the, the health plans and the providers, but was still able to kind of measure relative prices. And then once that work had been done, Chia kind of inherited that work. So that model, is one we're very happy with. If there's sort of others will pioneer some form of measurement, then we can take it on as part of the baseline. And you can also think about it as like if in Moneyball, somebody has to create the baseline statistics. Right. I mean, not each team isn't scouting every other team in order to help figure out people's batting average and the pitchers, earned run average and so on. That's published by the league. Everybody has access to the baseline statistics. Now, whether your team wants to really emphasize on base percentage or you want to, what you want to do with the statistics, that's really a policy decision. That's like what David's team does is they think about should this merger, is this in the best interest of the Commonwealth or that policy level stuff. But Chia is creating the baseline statistics that let us address questions like that, not just by intuition, but with, using numbers.
We're throwing out a lot of metaphors now. I won't add to that.
What's yours, David?
I just wanted to highlight another example of this, which is, there was a policy and research question around what is the proportion of medical spend that is going to primary care and behavioral health care. And this is something that other states are beginning to measure and try to understand and creating policy recommendations to enhance, to increase the proportion of medical spend in those areas. That's something that the governor proposed. And, really in that instance, there was, we had done some research and work and used some data assets to try to come up with kind of a back of the envelope estimate. But then Ray and his team institutionalized that and created the technical data specifications for the health plans to be able to report that to the state to create that baseline so that every year now we'll have a better understanding of what that primary care and behavioral health care proportion spend is. Do we think it's sufficient? Do we think it's insufficient? Those are, broader questions, but what Ray and his team do is kind of create that platform and over time have built that to inform, the work of many others. So you're absolutely right, Faye, that, it is not as simple as just data assets and answering questions. It really is I think a well-run interagency collaboration. And I would also give a lot of credit to Undersecretary Peters here as well in being another part of how all of this fits together.
Agreed.
Other thoughts or questions from the council members?
Yeah. Oh, sorry, Meredith.
That's okay. Go ahead.
Yeah, I mean, I know just kind of like a little bit inspired by like the APC, the all payer claims database presentation we got. I was wondering if, because I know these report cadences, like the monthly reports, like annual reports, stuff like that. I was wondering if like more, I guess from like a data infrastructure side, if there's any thoughts on like pursuing like a self-service model for some of that stuff, or maybe integrating that into I don't know, like the all payer claims database project. I don't know. That's a little bit broad, but yeah, essentially just like more so like some of the more things that are on like a cadence, like creating like a self-service delivery model.
Interesting. So for self-service for like for external publications or for like HPC, I mean, the goal of the new APCD platform is that our end users won't rely on us to give them the data. They'll just natively be on the platform. So that'll be a completely, and we eventually want to get to the point where researchers can do that. We're trying to think of the layers of the onion as to how we can do that with that platform.
Yeah, absolutely. Sorry. Yeah, I know this isn't very well thought out, but I suppose like a lot of the transactional information that you guys collect, like outside of just like the claims data, like if like integrating that into like a wider model for like researchers or like internal use or something.
Oh, it's interesting. Yeah.
So
I mean, we have a very sophisticated sort of intake platform, but I do think the world is expecting data to become much sort of faster. The work we've done with the Apcd to make it more of a platform that's online, I think that will be coming to a lot of what we do because, well, our case mix reporting went from annual to monthly. That type of thing, you know, that's, I think to satisfy that type of demand, I think that you'll start to see more self-service, more automation and kind of how we intake and stage data. So yeah, I think that's coming. Meredith, did you have a question?
Yeah, sure. I mean, I was just thinking, Ray, in terms of the data assets primarily, where you think the biggest opportunities are. I know, as you always remind us that you are serving your various customers, the legislature at the top of that list. But it strikes me that outcomes and quality data, I mean, there are sort of an inherent limitation everywhere, but I wondered if you've thought about the possibility of integrating some other kinds of registries or other information. What do you dream about when you think about new data that could really drive the mission of Chia?
Sure. Some people would be reluctant to talk in a public meeting about sort of something as if they're just sort of like whatever, just rattling around with.
Sorry.
But no, I've got thoughts on that. So let me.
What do you dream?
Exactly. What do I when I dream of data? Well, so I do think that a lot of this is about making our data more available to people, making it easier to get at the data for our data users. I think there's a bunch of things we can do to improve just our data operations of servicing customers and so on, that it's not about more data, it's about just doing a better job. And even to our existing data, there's just lots of analyses that we could do off of it that haven't been done yet. So I think there's lots of room for improvement. But if I think of, without getting into entirely new types of data, but I will say, lately, as the federal government has locked in the standards for the US Core Data for Interoperability specification, the US CDI, suddenly you have a really well-defined set of clinical data elements from the federal government, heavily leveraged by, you know, ONC, CMS. Really every provider organization is supposed to be able to generate this at the push of a button. We collect data from provider organizations. We have the authority to collect data from provider organizations. It feels like it would be fairly trivial for us to start collecting some of those data elements. But having said that, I also think that trivial in some sense, I think that the implications of it are very large. I think that we would never want to do that without really thinking it through with the HPC, with the OHHS, understanding from the stakeholders their concern, their views of the subject. But with this well-developed specification, it is sort of push button easy. The federal government has made a real issue of this interoperability of EHR data. It's now push button easy to get at things like medication list. Imagine if we could enhance case mix with medication list, or any number of other things that are on that US CDI specification. So anyway, so as I said, we've not been historically in the field of collecting EHR type of information. I mean, other than diagnoses and procedures, but if every single provider has to have the ability to do it at the push of a button, it certainly raises the question of, I mean, it would really, I mean, enhance our data assets to add some of that to case mix or Apcd.
Right.
So
yeah.
We're thinking about it. We'd love to get your thoughts on it. And do you have any thoughts off the top of your head?
No, I think that's really interesting. That's sort of, I can imagine, you obviously very correctly point to all the stakeholders. I can imagine that there is a space in the policy agenda where the providers, the payers, the legislature might agree that enriching what we know about clinical risk factors, like you just indicated, is good for everyone. If we're publicly reporting prices, if we're publicly reporting outcomes, and we're paying that you might actually get some consensus around the benefits of enriching your data using EHR data. And I see Laura nodding. I'm sure that's something that she's thought a lot about as well.
Yeah, Laura, any thoughts on that? Because I know that the whole interoperability space is one that you have followed closely. Does that, do you think that there's an opportunity there for us to leverage that specification for the type of work we do?
I do, and I think that it accrues benefits that probably are unknown and unknowable even at this point, once we got the information and be able to combine it. And I do see a renewed push. One of the things that holding the mirror up to our delivery system and seeing the reflection that wasn't pleasing that COVID provided us, it was this understanding of just the critical importance of being able to share data, to being able to combine databases, and to prepare for the next pandemic, as well as clean up after this one, and understanding all of the holes and the gaps that we had in data that did not serve any of us well. So I think there's a new opportunity here for data sharing sorts of conversations to be had in a different context.
Great point. Thank you. So yeah, so that certainly strikes me as one of the types of data that we could that we're going to think very carefully about getting. We are in the process of geocoding our data assets. We had historically taken address out because we had only used it for making sure we could uniquely identify people, and then we got rid of it. Once we created an ID. We don't even collect the address information now. It's hashed at the submitter site, and we still use it to identify individuals. All we kept was the 5-digit zip code. But we're now moving to a model where we're going to have an outside party create geocodes so that we can tag. I think this has already been done with CaseMix or with the hospital discharge database with the census block group number for every record. And so while we won't know their address, we will know their census block group. And so suddenly we can start doing geographic analysis in CaseMix, and we're going to be bringing this into the Apcd as well. So that's going to be really powerful in terms of health equity analysis. That's even before we get to race and ethnicity data, geocoding both of those data assets is going to go a long way or will really improve our ability to do analyses. So working on that. Yeah, I think, we have a bunch of thoughts on what we ought to be doing more, but certainly hearing from the Oversight Council, and this discussion isn't a one and done. I mean, it's anything as people think about this, we'll be talking about this in the future, or email or call, with any comments you've got, but we are trying to think about what additional data we might want to collect. But also be realizing kind of everything we do creates a burden on the data submitters and also costs money on our end, which is ultimately paid for by the data submitters. So it's always a careful exercise in deciding if we're going to do anything additional.
And I'm looking around, any other ideas, thoughts, suggestions?
There was another point that gets to in terms of new work. So you've seen now the all-payer claims database and how we've enhanced it. And David talked about how kind of different analyses, they sort of shift place over time depending on whether they're brand new or how hard they are to do. With the Apcd, we do think there's a bunch of analyses, some of which the HPC has done, like on emergency departments or out-of-network billing, that we can probably start generating standard reports around that. So we are looking forward to coming up with sort of an agenda for how we're going to use the Apcd, because it's, before we really were limited in terms of how much analysis we could do. It was really, we did what was available to us essentially, but now we're going to have so many potential analyses, we're going to have to, I think, work with our sister agencies to understand what they want us to prioritize. But one example would be, each year with the annual report, or not each year, but for the last several years, we've seen hospital outpatient services growing faster than other components. And each year, Chia is asked, do we have a sense of what's going into that? And with our aggregate data, we just can't say. With the all-payer claims database, it was really difficult to do that because we didn't have groupers on the claims. And so it was really difficult to look at encounters in the hospital and encounters that were out of just in general, hospital encounters were challenging for us. So with the new system, we should be able to analyze, do some sort of baseline analyses of hospital outpatient expenditures, but they would still be more in the kind of establishing the factual foundation, and then the HPC could, if they chose to, if the commission wanted to, pursue the issue further. So we'll be both, I think, looking for new types of data, but also trying to think of the highest value new analyses that we need to be doing in the coming years. So it's really both new data and new analyses we need to think about. Okay.
That's it.
Any other questions or comments on on that. As I said, I will be coming back in September to talk more about priorities, because I felt that we needed to describe the landscape first before trying to talk about relative priorities, because I think it's difficult until you get a sense of the full scope of things we're doing. So in September, we'll follow up this discussion by talking about, for example, some of those things I just mentioned, some of the new activities. Not all of them will, we don't have bandwidth for all of them. And so as we're trying to think about our analytic priorities for the coming months and years, that's something that we're thinking about internally, and we want to discuss with the Oversight Council in September. So this was just a preparation for that. We will share with you the updated document when it's done, because I do think it's important to, or it's useful to have a good, crisp description of Chia for our key stakeholders. So we will be following up on this particular discussion a couple of times.
Okay, very good.
So I don't think there's any other agenda items for today. Alex, that brings us to the end of the agenda, correct?
Yes, that's right.
Yes. Is there anything you would like to add, Ray? It was a brief, executive director report. So I assume you're still all chugging along.
I think everything other than, as I said, the last few meetings, we've been focusing on the kind of the very tactical, the sort of moving to remote and a lot of the increased work that we were doing in response to COVID. This was an attempt to step back and take a slightly longer view of a couple of issues. And so I hope that was useful to the council.
And help us as you tee up the question of analytic priorities. What is, your definition? How granular are you looking? It would be very helpful, like you teed up this conversation.
Great. Well, so I will, well, first I'll be, prior to that next meeting, I'll send out materials that tee up these discussions. But, just as I said, we'll be talking at the level of, I think, fairly large capabilities like geocoding the Apcd and case mix. That's number one, it's a lot of work. And then there's a lot of analyses that would flow from that. Using the Apcd to do relative price. We're releasing the relative price report this week. As I said, we know it's used a lot by the market participants. We also think it's a fairly imperfect methodology. Not to criticize it, it's wonderful as far as it goes, but it's a little bit dated. And we think the Apcd, we could do relative price and break it down by service category. So instead of just giving providers a single number, we might be able to give them different numbers based on what type of services we're talking about. So that's an example, but that would take some work. We'd have to socialize that with the HPC and other stakeholders. We'd have to, the external users. So we have a bunch of ideas for extra things we could do. All of them are worthy, but we would really like the input of the Oversight Council and others. We're having these discussions, and we're also going to go to the HPC, ask them for their wish list, go to EOHHS and DPH, ask them for their wish lists. So, it's all coming together, and this will take, a few discussions, I think, but in September, we'll have a good discussion about all these new priorities we're trying to figure out how to fit in.
Ray, will you be able to synthesize for us and sort of present the gestalt of what you heard from all the other stakeholder groups, or will that be sort of running in parallel, and so you won't have that information for us to take a look at? I'd like to understand what the major stakeholders see as the priorities.
Oh, it's an interesting point. Yes, I think we've been mostly kind of doing this as an internal thing, but as this gets more mature, we should actually reality check it with the stakeholders and get their input. Yeah.
And I think for us to kind of understand what the stakeholders are saying, so that we're not operating and making suggestions in the vacuum without understanding what the stakeholder priorities are.
Yeah, I think that would be very helpful. Thank you, Laura.
Excellent suggestion.
Okay. Thank you. Do I hear a motion to adjourn?
So moved.
Thank you. Thank you, Laura, Meredith, and thank you, Ray, and thank you to the entire team, both for all the work that's going on and reporting that is happening, and have a wonderful summer, everybody, as we open up to life again.
Absolutely. Thank you very much, Vice Chair Donahue, and everyone. Let me know if you need
Everyone.
Take care.
Bye, guys. Good seeing everybody.
Okay, bye-bye.